Hi, Dr. Mellard. I'm doing my video presentation for Unit 4 Case Connections. I chose case number 2 and 4, and I will get started by reading case number 2. Below, there are 3 scenarios. For each scenario, determine what is a likely enzyme deficiency, which amino acid is no longer metabolized, do any amino acids become essential as a result of the deficiency, what potential vitamin supplements may be useful for the condition, and what steps in the metabolism they could potentially help with. So scenario 1 is a full-term baby girl was born by normal vaginal delivery and released from the hospital at 3 days of age. At 9 days of age, a screening test for branched-chain amino acids came back positive, and the child was readmitted to the hospital for further evaluation. There was no history of any genetic disease on either side of her family, and both of her older siblings are well. First question is, what is the most likely enzyme deficiency and which amino acid is no longer metabolized? Her positive test is caused by a deficiency of the enzyme branched-chain alpha ketoacid dehydrogenase. The amino acids that are unable to be metabolized are the branched-chain amino acids, which are isoleucine, leucine, and valine, leading to the accumulation of branched-chain amino acids as well as alpha keto acids. Second question, do any amino acids become essential as a result of the deficiency? No, they do not. However, what does become essential is dietary modifications and the avoidance of the branched amino acids, isoleucine, leucine, and valine. What potential vitamin supplements may be useful for the condition, and what steps in the metabolism they could potentially help with? To answer this question, one would have to know the subtype of her disease. For acute metabolic decompensation requiring medical intervention, such as hospitalization, the primary intervention is quickly lowering serum concentration of the branched-chain amino acids. That is done by infusing glucose to stop protein catabolism and stopping all of her dietary protein intake. You could also consider infusions of bicarbonate for severe metabolic acidosis. For other subtypes, thiamine can be of therapeutic usefulness depending on which subtype of branched-chain amino acid deficiency she has. Scenario 2, a 69-year-old woman presented with a 30-year history of lower back and large joint pain of the hips and shoulders. On examination, blue-gray pigmented macules were present over the cartilaginous portions of the ears and on the sclera. Past medical history included aortic stenosis. What is the most likely enzyme deficiency and which amino acid is no longer metabolized? The enzyme deficiency is in homogentisic acid oxidase. The amino acids that are no longer metabolized are tyrosine and phenylalanine, but clinically more significant is the buildup of the homogentisic acid. Do any amino acids become essential as a result of the deficiency? No. What potential vitamin supplements may be useful for the condition, and what steps in the metabolism could they potentially help with? There has been an abundance of research surrounding the supplementation of ascorbic acid or vitamin C. Vitamin C inhibits the polymerization of homogentisic acid. However, in current research, its efficacy has yet to be proven. There's still a lot of research going on about what type of patients this is beneficial for. There is an herbicide called, this is a tough one, nitisinone, that is shown to significantly reduce the amount of homogentisic acid by reducing the enzyme responsible for its synthesis. This will lead to high levels of tyrosine, and there aren't any long-term studies that focus on the side effects of tyrosinemia secondary to the treatment of alkaptonuria. So basically, this medication leads to higher levels of tyrosine, but based on the current research out there, which isn't much right now, high tyrosine levels have not been shown to impact the patient significantly in a clinical way. So I think they've just been using it and trying to track the tyrosine, and people's symptoms. Scenario 3, a 4-day-old infant is being followed in your clinic. Her birth weight was 5.9 pounds and the pregnancy and birth were normal. Results from her newborn screening demonstrated phenylalanine level of 6.6, which is above the normal range of 1 to 2. What is the most likely deficiency and which amino acid is no longer metabolized? The most likely enzyme deficiency is phenylalanine hydroxylase, and the amino acid that cannot be metabolized is phenylalanine. Her phenylalanemia could also be caused by BH4 deficiency. BH4 is a cofactor for phenylalanine hydroxylase. So either one of those could be causing her high phenylalanine levels. If the cause of PKU is a second question, do any amino acid become essential as a result of the deficiency? If the cause of PKU is BH4 deficiency subtype, then tyrosine becomes an essential amino acid in her diet. What potential vitamin supplements may be useful for the condition and what steps in the metabolism they could potentially help with? Yes, for PKU, the main treatment involves supplementation of large neuroamino acids combined with a low protein diet. For the BH4 deficiency subtype, BH4 supplements have been shown to greatly reduce phenylalanine in just a few hours after taking the BH4 supplement. So for that subtype, BH4 supplements have been shown to really help patients with the accumulation and metabolism. Case number 4. A 58-year-old woman presents to the emergency department with progressive fatigue, weakness for the past 6 months. She is short of breath. She can't walk only a few blocks. On review of systems, she mentions mild diarrhea. She has noted intermittent numbness and tingling of her lower extremities and loss of balance while walking. She denies any other neurological or cardiac symptoms, no history of black or bloody stools. On examination, she's tachycardic with a 110 heart rate. Other vital signs are all within normal limits. Head and neck examination is notable for pale conjunctivas and beefy red tongue with loss of papillae. Cardiac examination shows a rapid, regular rhythm with a grade 2 out of 6 systolic murmur at the left sternal border. Neurological examination reveals decreased sensation to light touch and vibration in the lower extremities. No depression noted. Hematology have been called to consult on the patient, and they've noted that she had a low hematocrit. They're suspecting that the patient has megaloblastic anemia. Which of the following vitamin deficiencies is the probable cause of this presentation? Discuss each option and note which deficiency is the most likely. So the first option is iron deficiency anemia. I said no. So iron deficiency anemia is the most common type of anemia. It's caused by insufficient amounts of the mineral iron. And iron is important for hemoglobin synthesis. Hemoglobin is a protein in red blood cells required to carry oxygen and deliver it throughout the body. People who have mild iron deficiency anemia usually go without any symptoms. They're pretty much asymptomatic. However, symptomatic iron deficiency anemia can cause fatigue, weakness, lack of concentration, paleness, or shortness of breath. So although some of the patient has some of these symptoms, it doesn't explain the majority of her symptoms. So ultimately, I said no to iron deficiency anemia. B6 deficiency. I also said no to B6 deficiency. So B6 is required for transamination reactions. It is also required for the conversion of homocysteine to cysteine by cystathionine beta synthase. That was a hard one for me. Symptoms include a rash. So sometimes a patient can have like a rash on their face, or they could also have present with psoriatic dermatitis on their scalp. They can have cracked lips, fatigue, tingling in the extremities, and seizures. So I said no to that. The next one is B12 deficiency. I said yes because I felt like this matched the patient's symptoms more. So B12 deficiency, this is the cause of the patient's megaloblastic anemia. B12 deficiency impairs DNA synthesis of the red blood cells, causing a mismatch in the development of the nucleus and the cytoplasm, resulting in an overly large red blood cell that contains immature segments within it. So big red blood cells, but has immature parts in it. These findings are most consistent with the patient's symptoms also, which include fatigue, shortness of breath, tachycardia, and potentially a cardiac murmur. Discuss how this vitamin deficiency impairs purine or pyrimidine metabolism. Folate is a carbon donor for the synthesis of both purines and pyrimidines. Folate deficiency will reduce the production of thymidylate synthase, which decreases DTMP, which will also reduce DNA synthesis. List potential laboratory findings that would assist your differential. So a patient would get a complete cell blood count, which would include a hemoglobin and hematocrit and mean corpuscular volume, which is what we call in nursing just the MCV, a B12 level, a folate level, methylmalonic level, and back in the day they used to do something called a Schilling's test, which thank God they no longer do anymore, which involved the patient taking oral radioactive B12 and then also getting an injection of it and measuring levels thereafter, trying to figure out why the patient has B12 deficiency. Anywho, that is my case study. Thank you.